Hi everybody, how you doing today? We're going to talk about Module 2. We'll kind of follow the slides, but I'm not going to do the slides, read the slides, and explain every slide. I just want to kind of hit some high points and some things that I think are kind of valuable, and some ideas for you to kind of pursue when you're looking at your discussion board and your assignment. Let's see, can I shut this slide out? Ooh, I look goofy. Let me turn it this way a little bit. Yeah. All this production work here. Anyway, I guess again, I want to spend a little time talking about the theory of this whole thing. This is an online class. Surprise, surprise. And when we think about all the advantages of an online class, and I've taken classes online, I've taught classes obviously online, and been also a ground student and taught courses on ground. The difference, I think, is that the ground course probably gives a lot more emphasis on the instructor giving you a lot of information, as opposed to an online course, which I think kind of gives the instructor, the professor, whoever, me, gives you some time to set some groundwork and some guidance, but it requires you to do a little more digging yourself. I always think for anything that you really teach yourself, all you're really doing is taking the experiences and the lessons taught from your other people and kind of incorporating those in your perspective. So to kind of get in plan, I think you got to do a little more work outside of class in an online course than you do an inside a class, because I think inside class, on ground classes, everything's fed to you. I think on outside classes you are challenged to write more, which is difficult, and then you're challenged to support that writing by research. So, as I say, we'll kind of go through, move my notes over to this side, kind of go through some of the thoughts on this class today, kind of talk a little bit about what I'm looking for in the discussion board that will be due first input on Thursday, and spend about 20 minutes, half an hour on this with you, and then kind of leave you off to your own devices. Chapter 3 and 4, to a lot of people, that this is like what we mean by community health. This is public health in a nutshell. I offer you that my opinion of these two chapters and these thoughts that we're talking about, this is the foundation of public health. This is the base of public health, and everything builds off of that. And it's a much more complicated, much more intense than just a little bit of epidemiology. You talk to most people, even people in our health care world, and they're going to talk about public health as pretty much epidemiology. We're going to kind of disagree or depart from that idea a little bit and look at lots of other things as we go through the course on public health. But I tell you that epidemiology, disease incidence, all the things we're going to talk about today are really the baseline. It's the jargon. It's important to understand that words have meanings and the jargon that's involved. If you get by anybody, you go to a new job, and I guess I'll tell you my bad story about life. As you know from my bio, I was in the Navy for a long time and had nothing to do with healthcare. And then I went to the University of Missouri and got my degree in healthcare, and thought I was like the smartest guy in the world. Now, the Navy is important about this because the Navy military healthcare is completely different than civilian healthcare. You just go to the clinic and they treat you, and you come home. You take your family to the clinic, they treat you, you come home. There's no bills, no nothing. It's just treatment. So I go to Mizzou and I learn all about all these great terms and all the good stuff you guys are learning. And then I go to my first job. And I was the assistant administrator in a physician group of about 35 physicians. And the administrator was a great guy, super, still, my mentor to this day. I call him up and we talk about things. He Now it's a great situation because if you're an older child and your parents now, you kind of change the role from being a little kid and have them tell you what to do. And now, in some ways, the parent and you, or my dad and mom, when they were alive, and I were kind of would talk the same. And then eventually, they say the child becomes the parent when the parent gets old and needs a lot of care. But anyway, my mentor and I, for the longest time, I'd call him up and run something by him, and then later on, he'd call me up, and we kind of have this discussion. So I went down to join him. He was president of the State Medical Group Association, managers and such. And the first day, get there, we went around, we meet a few of the doctors. He says, we have a 10 o'clock meeting. And I go into the 10 o'clock meeting, and it's with the business office. And I sit down and get introduced to everybody, all the good stuff, and we start the meeting. And the women and men of the business office are talking about details, and they're talking about EOBs. And they're saying, we got to put this with the EOB. The EOB has to go there. We want to file the EOBs and how we have to handle the EOBs. We want to attach the EOB to the charge master, and all these other kind of things. And about an hour in the meeting, and I was very smart by just sitting there and what's the old joke? It's better to be quiet and have people think you're stupid than open up your mouth and confirm all their suspicions. So I was quiet and have them thought I was stupid. So we get out of the meeting and walking back to our offices, and my boss, Bob Christian, says to me, well, what'd you think of your first healthcare meeting, Mike? And I said, well, it was pretty interesting, and I made some comments, and I said, but I don't know what an EOB is. And I said, I felt foolish asking what an EOB was. And now, explanation of benefits, we all know it. Like 3 minutes later, Bob fell off the chair laughing at me. He said, you're the big educated guy and you don't know this. But anyway, so the jargon is real important. When I was in the Navy, there were words, like port and starboard and overhead and deck, which is left and right, ceiling and floor to civilians. But you couldn't say the floor, you had to say the deck. And so what we're looking at in the first probably 10 or 15 slides, maybe less than that, but the first couple slides in each chapter 3 and chapter 4 is the definitions, the jargon that we have to use. Important to do. If you don't know when you start using words like epidemiology, endemic, pandemic, and you use them in the right way, people say, oh yeah, you have credibility, that person. But if you use words like people get sick for a long time, or this sickness is all over the world, it's spread like wildfire, you sound a lot smarter if you say it's pandemic. So anyway, I think it's important that we pick up this jargon along the way. There's somebody at the front door, but anyway. So we pick up the jargon. So we look at what's important in these objectives. And the first thing is, what is epidemiology? And epidemiology is population medicine. It's not medicine looking at little Johnny and little Sally. It's medicine looking at communities, cities, states, worlds, social economic groups, races. It's looking at how disease affects whatever cohort you decide to slice it and dice it up with. We want to collect disease status on the community. Who's sick, when they're sick, why they're sick. And again, we're eventually going down to try to find what we could do to make it better. The days of I'm watching this show, The Outlander, on Stars, and it's about time travel, which always has interested me. But anyway, they talk about things making people sick, like the vapors. We know that's all baloney, that every disease process is caused by something, and every sickness is caused either communicable or non-communicable disease. And so we want to look at reasons why, and we continue to look at reasons why. Why do many people die from heart attacks? Why do many people have breast cancer? Is there something in the environment? Is there something in their genes? Is there something that we can do to make that happen less? So epidemiology is what lets us look at that. Now, We all remember from some other courses that we've had when we talk about finding root cause, finding the reasons things happen, and we say you can't solve a problem until you find why it is a problem. And that's kind of also the thought of epidemiology. We want to look back and say, what is causing this? Now we can do something to solve it. So we don't try to, and most in business, they've adopted this same idea and they use medical terminology. So you'll be in a business meeting sometime in some unrelated field, sales or something, and they'll say, we're not looking for the symptoms, we're looking for the causes. And that's exactly what we're talking about here. Epidemiology goes way back to the early Greeks, and they, in fact, were the originators of the vapor term. They believed that the air coming off a swamp was causing disease, and maybe in some ways there were, rotting, decaying vegetables and such. But anyway, and then the famous case of epidemiology that we always talk about is the Jon Snow. No, that's not the Jon Snow from Game of Thrones. This is Jon Snow, a physician in London, and you can read the story in the book. But he started plotting cases of cholera and found that they all centered around, they were really clustered around one area. And they couldn't figure out what was causing it, and they looked at what people had in common, and they all used a water pump because they didn't have indoor water at the time, so everybody used the same water pump. And so he took the handle off the pump, and the cholera cases decreased. So he identified the cause of cholera as the impure water coming out of the water pump. And that's when anybody talks about epidemiology and tracking and all these things, Jon Snow cases like the story everybody tells. So then we go on to the idea of what we're trying to do. We're trying to figure out rates, how fast and how complex outbreaks happen in different places. We're trying to figure out cases, the number of people that are sick. We want to look at the rate of a given population over a period of time, and we could talk about some of those: morbidity, mortality, death, sickness, birth. So all those terms are really looking at rates in a given population. We also wanted to kind of identify a population at risk. We looked at one of the papers. I noticed they talked about, one of the discussion boards talked about high incidence of high blood pressure among African Americans. Well, why is that? Do we know? Probably not so much yet, but it's something we can look out for. So when an African American male, I think is the higher one. I know both African American cohorts have a higher incidence of blood pressure problems, high blood pressure problems. But that's something that the doctor has a clue to look at right away. So if you come in and you're not doing particularly well, it gives the doctor at least a place to start. So we want to talk about this idea of incidence and prevalence, the two key words, the whole background of epidemiology. Incidence is the number of new cases divided by the population at risk. So it's the number of new cases. So what that really is showing you is how fast it's growing. And the attack rate is the incidences for a single disease outbreak as a percentage. We always hear about the incidence cases, especially with acute diseases, and acute diseases are less than 3 months. Flu season, they start doing the map, and showing you which states have a higher incidence of flu than others. Prevalence is the number of new and old cases combined, divided by the total the population. Prevalence is much more in non-communicable, in chronic diseases. Acute diseases like the flu, we look at how it grows and how it drops down. We use a lot of prevalence in long-term chronic diseases. So, for example, the AIDS epidemic, diabetes, are the number of people that have diabetes and adding on to diabetes growing or falling? And so you can see how those two numbers would be used pretty constructively to look at trends, to look at what's really happening in the world. We talk about attack rates, how fast they're growing, how large the population is becoming attacked. So we look at once we get the information, the gross information, we can look at how we're going to slice and dice it. So we can look at just crude rates, like the whole population, the number of AIDS cases. Then we can start looking at age adjusted. We can start looking at socioeconomic adjusted disease by age rates, by race, by sexual preferences, by economics. So we can start now taking disease, both incidence and prevalence, and start breaking it down and looking where we have to put our efforts. CDC in Atlanta is the king for that. They're collecting the information. We'll talk a little about information collecting in a tad here. We talk about this idea of disease schemes, of how let's report it. We want to know what we have to report. Now, we don't report every single thing. Sometimes we report special things, like during flu season, we report the flu, but we report the individual units, report to the local health board, reports to the state, reports to the Fed. So we kind of keep track of illness, how that happens. Now, we all know that electronic medical records now, have really made this pretty easy. If you had to go back in the day when I first started out and say, how many diabetics do we have in the practice? The only way we would know is we would go into the billing information and look at the CPT code for diabetes and then count those. So you would only get counted as a diabetic if you came in for a diabetic visit. So if you're a diabetic and you came in, the first time you came in and we said you have diabetes plus you have a heart disease, and the CPT codes were all coded out for heart disease, you might fall through the cracks. Now, with electronic medical records, we can gather that information a lot faster. What do we have to report? A great job in the hospital is in the cancer registry. They report all cancers to the tumor registry boards, they're called in some hospitals, and report that so we can look at cancer. Some of the things that, as an administrator in a practice, I can tell you, the Navy, we used to have an expression, ordnance rules are written in blood. And what that means is, you change the rules when you make mistakes, so you learn more from your mistakes. So some of the things that we have to report that I never realized is dog bites. Anytime somebody comes in with a dog bite, you have to notify the county dog collector. Gunshot wounds, violence, that has to be notified as a problem too. So you got to check out what you're doing there. So we look at the standard ideas in health. We talked about mortality, morbidity, death, sickness, birth, life expectancy, and we'll just touch a little bit about life expectancy here. I'll admit that I didn't realize how life expectancy worked until much later in my life than I thought. I'd be sitting there and I'd open up the paper and it said, the average life expectancy now is going up to 73 from 72. And I'm thinking, great, I just got another year of life. Wrong answer. How life expectancy works is from when you're born, they determine your life expectancy. And it doesn't change very much over your life. So a person born in the late 1940s like me, my life expectancy is 72, and someone born today like my little granddaughter, her life expectancy is 77. So when you say now the life expectancy for the American is 77, that's not me. I didn't gain 5 years all of a sudden. So life expectancy is really, and there's a chart in there that shows you it originates from the year that you're born. Now it does change a little over the time, especially if there's significant medical changes. But it doesn't, every time the life expectancy change, that doesn't give you 2 or 3 extra more years in life. We want to talk about years of potential life lost, and that's available in lots of places. What we're saying, and in fact, I think your discussion board question talks about that, is this is where death occurs before the life expectancy. So if my life expectancy is 72 and I punched out of the system, got on the other side of the grass at age 58, why? What? Why didn't I make it to my average life expectancy? So we want to look at what that means, um, and it really gives an awful lot of an idea on the overall health. Now, if you just read the book on this, you're going to give it probably a answer. So it might be a good idea to go to Google Scholar or to the Grafton Library and look up the whole idea of years of potential life loss, because it's a real powerful thing. Now, we even slice that down even to some more areas. Um, Health adjusted life. Now, if we use these things to look at allocation of dollars, basically allocation of resources. Now, we've all taken the economics course, and we know, at least my favorite definition is economics is the allocation of scarce resources. We don't have unlimited resources. It's not eat all you want because we could always make more. We only have certain things and places to put money. So looking at years of potential life loss, looking at years of disability adjusted and health adjusted years are real important for how we're going to spend our healthcare dollar. The joke is, or the joke, it's not a joke, it's as you get older, it gets real. What's better? Is it better to do something that lets a person live to 75, vital, travels, does the garden, does all that? Or is it important to have a person live to 90, but the last 18 years they can't get out of bed? So what we look at in the different ways we adjust on life is what is life, how valuable is it, and how much should we spend to get a certain style of life. So what's the number of healthy years expected? What's the number of a year lost to a healthy life? Again, I think I'm sure we also my mom had Parkinson's disease, which she came fairly strong at about in her early 70s. Now, my mom lived till she was 91, but she lived for the last 20 years with Parkinson's disease and tremendously limited in what she could do. And so how much of her life, when we look at her life, do we say she led a great life to 72 and after that we could X her out? Not really. I mean, she saw her grandchildren, she saw me getting married, all those things in life that you experience, but she didn't have a productive life according to society. She couldn't have got a job. She needed extreme amounts of care. So when we look at that's kind of the thing we want to talk about. Where do we gather all this data? We gather, obviously, some data directed from reporting schemes. Other data we gather through the Census Bureau. Secondary data. You as a practitioner will almost always have to find secondary data. We just, it's back to marketing studies. We'd love to have a marketing study every time we want to do something, but it costs money, can't afford it. So what we will do is we will use data that mimics or fits us the closest fit to where we're at. So if we're looking at introducing a program, we'll look at the data and slice and dice it over age cohorts. We'll see what the census says is the age in our area, and then we'll look at the different health functions as a function of those ages. So if we live in, for example, Florida, if you live in certain areas of Florida, as my wife always calls it, God's waiting room, that there's a tremendous population of senior citizens, of baby boomers now. Their medical needs are obviously much different than a university town that has 25,000 kids between the ages of 17 and 25 or 30. One of the examples on this data thing is in the Navy. Everybody in the Navy is under 40 with few exceptions. So our cohort, our things we look at. For example, in the Navy, we spent a lot of time looking at dental care because we lost more time from ships for people that had bad teeth and had to be evacuated than people that had acute disease. So we want to look at that secondary data and use it as powerfully as we can in our practice because you're not going to get very much primary data. We always should look to data. We always should look to things that happen because we could spend the next hour and I could tell stories. The one I always think about is I was at a practice one time and the orthopedic doctor decided that we needed a sports medicine program. And because he gets calls on Saturday from people that got injured in sporting events on Friday night football, and if we had a sports clinic, we could clean up. Well, we did in administration, we did a quick study and found out that we didn't see that many sports injuries, not enough to support opening in a clinic on Saturday morning. And so we had a meeting and we talked about it, and the senior doctor had been there for, he was with Noah on the Ark, gets up and said, I've been here for 27 years and I know this community better than anybody, and this is what we need. Well, he's just kind of talking off his brain and not off statistics. And we could show that the community was aging, that the number in the schools was declining, and it didn't make any sense. But he made the big pitch to all his colleagues, and boom, we opened a sports medicine clinic. We had it for about 14 months, and it had 14 consecutive months of losing money, a lot of money. So we shut it after a while. And of course, I ran up to that doctor and went, I told you. No, I didn't. I just sat and smiled and said we were right. So what we want to do when we start making decisions is get as much data, as much hard stuff, as much research as we possibly can. Shooting off the hip is great at times, but it's why should we? So we're talking about all the different surveys, investigations, epidemiological studies that we can do. Remember that we want to talk about who, when, and where in epidemiology. Who's affected, when are they affected, and where is it affection? And that way we can start coming up with plans. Epidemics, we can develop a whole idea on epidemics. We promulgate a curve, and we see that every year, that we first started getting flu in November, and then December, and then January, and then February, and then March, and April it starts dropping down, bell-shaped curve, obviously. So we look at the curve and see where we are on it, and if there's deviations in the curve, like every bit of business that we do, the variance analysis is of, we think the curve should be here, and it's not. Why? What's going different than this year than next? We do a lot of analytical studies where we observe things, we make changes, we look at why certain areas aren't affected as others, and then experimental studies. We always are after determining a cause. There's just something about us all. We always want a cause, both in scientific things and non-scientific things. How many times do you hear people say, why did that happen? Why? We want to have the criteria, how we develop the cause for disease, what we see about it, and what we can do to correct it. And epidemiology is that science. It gives us the data that we can make the interpretation from. So we're not saying the vapors off the swamp are causing people to be sick. We can say, this is what we found, this is why we found it, and this is how we treat it. So that's probably chapter 3. Moving on to chapter 4. Again, we think this is the beginning and end of public health. It's not. We start the chapter off with a lot of definitions. Acute, less than 3 months. Chronic, more than 3 months for a condition. So obviously acute, you have a sore tooth. Acute condition, they go in, they fix it, they pull it, they crown it, they do something with it. A chronic condition, diabetes, you have it for the rest of your life. AIDS, such as that. So then another breakdown is communicable and non-communicable diseases. Communicable, I can pass it to you. A non-communicable is not transmittable in the biological sense of the word. We find, and sometimes when we think about that non-communicable disease, we think, yeah, in some ways, why does America have a problem with obesity and some other country doesn't? It's not obviously communicable, but there's a prevalence of it here, I guess. We want to talk about the pathology, what causes disease, and we talk about the communicable disease model. Pretty much you guys are familiar with this, I'm sure. Why does everybody wash their hands with Purell? It's so funny. For a while there, it was like every place you went, people were. But we talk about hand washing in healthcare institutions all the time. Why? Because it is demonstrated. It's just right there that we transmit a lot of disease through this host agent model from your hands. Just coughed in my hands, brought up stuff from my lungs. Now if I went out and cooked dinner without washing my hands, those things transfer. We talk about the idea of chain of infection and such. Some of the other things is zoonosis and anthropanosis, these diseases that are caused by, that reside in animal populations, and then diseases where the only reservoir is humans. Animal populations, malaria. The mosquito, the blood is in some animal that has malaria. The mosquito sucks it up, comes over and sticks you. Now you have malaria. Modes of transmission. What is it? So this is kind of like a shopping list of, once you get the data, start to figure out where it is and what you can do and how you can take care of it. Non-communicable diseases, everybody's worried about the plague that's going to end the earth. There's several academic articles out there written about that said this just that pandemic could never happen. And if you look at and read in your chapters about this and look up about the idea of pandemics, what happens is you run out of patience. It's just they can't spread that fast. But anyway, by themselves now, biological agents spread by the bad guys maybe. We want to talk about what we have to do to intervene and prevent diseases, and that's basically what we're talking about. Primary prevention that forestalls the injury, secondary prevention, early diagnosis, treatment early on, and then tertiary prevention, long-term, re-educate, change the way we do things. Just sit and be in amazement sometime that clean water. I mean, yeah, I'll get done here and I'll think nothing of going in the tap, drawing a glass of water and popping it down. How many people in the world don't have that? How many people in the world die of diarrhea caused by bad water? Lots. It's one of the leading causes of death. So when we look at public health, we look at some of the things that have been done here and in the more developed countries that we need to get into the less developed countries. That's why I see I was a Rotarian for a long time, and that was one of our things is clean water for the world. So we look at the prevention of disease, the idea of active immunity, vaccinations. Don't get me started on vaccinations. I think the anti-vaxxer people should all be put in a little island and somewhere off the coast of nowhere, and they can sit and babble to themselves. Life is all about risk, and there are people that there are a problem with vaccinations, 1 in every million doses or such. But that's the cost of being alive. Nothing is perfect, but not getting your children vaccinated, that's criminal. So we talk about non-communicable diseases, lectures, education, trying to help people, clubs, working out, leading healthy lifestyles, eating healthy food. So that's kind of the whole picture of these last two in a quick nutshell. Again, on your discussion board question on years, YPLL, years of productive life, kind of expand why is that important? What can you see? There's a lot of great articles, and I think I referenced one or two in your supplemental reading, but just Google it. And there's Google, and I don't know if you know, there's a thing called Google Scholar, which is much a little more depth, and it takes you out of Wikipedia. And then obviously our library is great. And then the discussion question. If you have any problems or questions, please give me a call. Don't suffer in silence. Nobody showed up last Thursday, and I don't care. I'm just there for you. So I'll do the same thing this Thursday. I'll come on at 8. If you don't have anything, or you're busy, or whatever happens, that's fine with me. I'm just there for you at that time, and we can do two-way, but you can call me, text me, email me any other time. Hope this helped, and keep up the good work, and we'll talk to you all later. Thank you.